Hello, dear students. I am Dr. Nikita Valluri, working as an assistant professor in Sridhartha Institute of Pharmacy. So, I am here to teach you this pharmacotherapeutics 3. And today, now, the topic which I am going to discuss is treatment of schizophrenia. So, in the last class, we have discussed what is the definition of schizophrenia, epidemiology of schizophrenia, etiology, and classification of schizophrenia, pathophysiology, clinical presentation, diagnosis. So till diagnosis we have discussed in the last class. Okay. So now today in this class we are going to discuss treatment of schizophrenia. Okay. So before going to the treatment, first we must know what are the goals of treatment. So the goals of treatment, the first goal is to elevate the target symptoms. That means whatever the symptoms are there, that has to be decreased. Avoid side effects. Avoid side effects because of using the medications which are used for antipsychotics, which we generally use, and improve psychosocial functioning and productivity. So psychosocial functioning means the patient should be able to mingle with others. He should handle the social things normally. So that means we have to improve achieve compliance with the prescribed regimen. So they should be adherent to the treatment regimen. That means they should take the medication regularly. So we must ensure that they are taking the medications regularly without missing the dose, and involve the patient in treatment planning. And also we should take the patient's thoughts and patient's willing in making a decision while you are treating. So these are the goals of treatment. And before treatment, we have to perform a mental status examination. So that is it's a physical finding. So though we have to examine the patient by asking few questions. So that comes under mental status examination. Physical and neurological examination, physical examination of the patient, neurological examination. So these three should be done. What are they? Mental status examination, physical examination, and neurological examination. So first, initially, we have to do these three examinations. And also, we have to collect the history, detailed history of his family and social history, psychiatric diagnostic interview, and laboratory workup like laboratory tests like complete blood picture, electrolytes, hepatic function, renal function, ECG, fasting blood glucose, serum lipids, thyroid function, and urine. In urine, in urine, we have to check what we have to check is whether there is any drug, so any drugs are seen in that, so that we have to check in this urine. So these were the different tests that we'll be going to conduct. Okay. First is mental status examination, physical examination, neurological examination. And along with that, we also have to conduct certain laboratory tests like complete blood picture, serum electrolytes, protein like LFT, RFT, hmm, urine examination, and fasting blood glucose, electrocardiogram, that is ECG. So all the regular examinations that we conduct for initially to any common patient, all the routine blood laboratory examinations should be done along with this collection of history in his mental status examination, physical and neurological examination. So after conducting or after going all these through all these, we'll come to a conclude that the patient is having schizophrenia, right? So after that, we should keep the patient on treatment. So what are the different medications that we are using for treating schizophrenia? It includes first generation antipsychotics and second generation antipsychotics. So these were the two different classes of the drugs that are given for schizophrenia. And what are the first generation antipsychotics? It includes chlorpromazine, flufenazine, haloperidol, loxapine inhalation like inhalation form, perfenazine, thioridazine, I'm sorry, thiotixine, trifloperazine. So these were the first generation of antipsychotics, and these are the trade names which were available for this. These are the trade names, that is thorazine, prolixin, halodol for haloperidol. So not only these trade names, there are different n number of brand names were available. So these were a certain or most common brand names that were generally seen according to the author which who have written in DPRO. So according to that, the common trade names were these, and the doses were like 50 to 150 5 mg per day. Like these were the respective doses, and this was the usual dosage range. The commons include when we are giving this chlorpromazine, we have to check for weight gain. Why? Because its side effect is weight gain. And next, fluphenazine is also the same. For haloperidol, higher dropout rate in first episode. So dropout means they'll not respond to that first episode, or immediately they'll be dropout can be seen. And so QTC prolongation can be seen when we are giving this thioridazine. And then coming to second generation antipsychotics, which we see commonly, it includes aripiprazole, asenapine, clozapine, iloperidone, lurasidone, olanzapine, paliperidone, quetiapine, risperidone, ziprasidone. So if you see the prescriptions in the psychiatric ward, the most commonly the drugs which you see include among all these chlorpromazine, fluphenazine, and among the second generation antipsychotics, you will see regarding this aripiprazole, clozapine, olanzapine, quetiapine, risperidone. So these were the drugs which you commonly see in the prescriptions in psychiatric wards in our hospital, in our global hospital. Okay, and asinapine, it has to be given only sublingual dose. And when we're giving clozapine, we have to check this plasma level before exceeding 600 mg. So this drug will remain in the systemic circulation. So we have to check this drug level. Therapeutic drug monitoring should be done. So this should not be more than 600 mg. And olanzapine, avoid in first episode because of weight gain. So if the patient is having only one episode and it was found to be the first episode, it's better to avoid olanzapine because it causes weight gain. And paliperidone, bioavailability is increased when administered with food. So it should not be like the effectiveness of the drug will be more when it is given along with the food. Ziprasidone, it also should be taken with food. So these were the common drugs which we have seen in treating of schizophrenia. It includes first generation and second generation antipsychotics. So what was the general approach for this? So second generation antipsychotics are also known as atypical antipsychotics, except clozapine, and remaining are the choice of drugs for schizophrenia. And SGA means here second generation antipsychotics. So already we have seen the list of the drugs which comes under second generation antipsychotics. So they have superior efficacy for negative symptoms and cognition. So it can be given for negative symptoms and cognition. And next, they are said to cause few or no accurately occurring extrapyramidal side effects. So they cause only less extrapyramidal side effects, and they does not cause any tardive dyskinesia. So about all these terms, I will explain later in the next slides. Don't worry about that. And less effect on serum prolactin than the first generation antipsychotics. So compared to first generation antipsychotics, second generation antipsychotics, they are a bit safer. Why? Because they'll be having less extrapyramidal side effects. They'll be having less chances of tardive dyskinesia, and also the effect on serum prolactin levels is also less compared to first generation antipsychotics. And second generation antipsychotics increase the risk of metabolic side effects that includes weight gain, hyperlipidemia, and diabetes. So those who are taking second generation antipsychotics, they are at risk of getting hyperlipidemia and diabetes, and also they'll gain weight. So this is all about the general approach. And also, according to some studies like clinical antipsychotic trials of intervention effectiveness, it's a study. According to that study, it showed that olanzapine compared with other second generation antipsychotics has modest superiority in persistence of maintenance therapy. That means among all the second generation antipsychotics, it's like olanzapine is a drug which helps for maintenance therapy. Okay, and always when we are selecting which kind of antipsychotic, so certain things to be remembered. It includes the need to avoid certain side effects, concurrent medical or psychiatric disorders if the patient is having any other psychiatric disorders, and patient or family history of response. So these are the things that should be kept in mind while we are selecting this antipsychotic medication. And clozapine has superior efficacy for suicidal behavior. That means if the patient has more tendency to undergo suicides, to commit suicide, then it's better to go for clozapine. It's better to choose clozapine. According to some evidence-based medicine, the patients who are having suicidal tendency, they were responded positively with clozapine. And predictors of good antipsychotic response include So predictors means like how can we come to conclude that the patient is responding to this antipsychotic medications is prior good response to the drug selected. So initially they'll be having certain good response, absence of alcohol or drug abuse. So they'll not undergo any alcohol abuse or drug abuse, acute and onset and short duration of illness, acute stressors, late age of onset. So if there is any late age of onset, and affective symptoms, family history of affective illness, medication compliance, good pre-morbid adjustment. So these were the things that we have to keep in mind when we are predicting the response of antipsychotic and medications. And negative symptoms are generally less responsive to antipsychotic therapy. Generally, what is a drug that we give for negative and cognition symptoms? Will be giving second generation antipsychotics, right? Yes, they will respond very much pretty much slowly compared to the positive symptoms. And an initial dysphoric response, that is dislike of medication, that means they'll not have a feeling to take that medication. They'll always avoid to take that medication, and they'll be having its anxiety or akathisia and poor drug response, adverse effects, non-compliance. So these can be seen when we are starting the medications initially. Okay, so this is a general approach. And pharmacokinetics. So most of the antipsychotics, they have a half-life of 20 to 40 hours. So after the dosage stabilization takes place, most of them can be dosed once daily. So they can be given as once daily dose, and also it's better to give it in night times. And antipsychotics highly lipophilic. So as already we have seen in the general approach that they cause dyslipidemia or hyperlipidemia. It indicates that they are lipophilic, and they have large volume of distribution and largely metabolized by cytochrome P450. So they accept ziprasidone. Ziprasidone will not undergo metabolism as quick as other remaining antipsychotics. So this is a chart showing the pharmacokinetic parameters of different antipsychotics. So you can go through this. First generation, second generation. So this is about this second shows bioavailability, half-life, major metabolic pathways, and active metabolites. So all this indicates the pharmacokinetic parameters. And coming to initial therapy, when we are initiating the treatment, so the first goal is during the first 7 days, or the goal first 7 days, what is our main goal is to decrease the agitation, hostility, anxiety, aggression, and also normalization of sleep and eating. So this is the first target in 7 days. First is what we have to decrease agitation, irritation, anxiety, aggression. So the patient should be made calm, and also he should have proper sleep, and also he should eat properly. So that is the first goal during the first 7 days. Okay. And for first episode psychosis, the dose range is about 50% of that of chronically ill. So for chronically ill patients, what was the dose that we are giving? In that dose, half of the dose only we should give initially in the first episode. And slowly we have to titrate the dose to an average effective dose. So first only we should not give immediately a higher dose. Slowly we have to increase the dose. We have to do titration. Dose titration should be done. And titrate iloperidone. Iloperidone is a first generation antipsychotic, clozapine, and more slowly due to risk of hypertension. Why? Because these two drugs, they cause hypertension. So because of that reason, when we are giving these two medications, we should slowly titrate. We should not titrate the dose all of a sudden also. Slowly we have to titrate the dose. Why? Because they cause hypertension. And after 1 week, at a stable dose, a modest dosage rate increase may be considered. So after 1 week, we can increase the dose. And if there is no improvement even after 3 to 4 weeks, even at that doses, then that indicates that the patient is not responding properly to that antipsychotic. So in that conditions, we should go for another class or another type of antipsychotic drug. And in partial responders who are tolerating to antipsychotics well, it may be reasonable to titrate above the usual dose range with the close monitoring. So if the patient is responding partially, then in that case, we can increase the dose a bit. We can increase the dose. by regularly monitoring the patient, by closely monitoring the patient. Rapid titration of antipsychotics doesn't not be recommended. So all of a sudden we should not titrate any, not only these antipsychotics, even neurological drugs also we should not titrate as suddenly. Slowly only we have to titrate the dose. And IM, that is intramuscular antipsychotic administration. It is done for certain drugs like aripiprazole, ziprasidone, olanzapine, and haloperidol. And these IM route of administration is done only when the patient is severely agitation or severely aggressive. In that conditions, we can go for this intramuscular antipsychotic administration. And however, so it takes some time to remission and hospitalization is required when we are giving this intramuscular injection. And lorazepam 2 mg as needed added to maintenance antipsychotic may be more effective for agitation than additional dose of antipsychotic. So if it's like in like initially we have given one IM injection among all those, and after that also if the patient is aggressive the next day, after some time he's calm, and after some time again he's aggressive, at that time instead of repeating the same drug, it's better to go for IM lorazepam. Okay, in order to maintain the dose. And combining lorazepam with olanzapine or clozapine is not recommended because of the risk of hypotension. As I already said that ilioperam and iloperidone and clozapine causes hypotension. So we should not mix clozapine or olanzapine with lorazepam. Why? Because it further worsens the condition of hypotension, and also it causes CNS depression and respiratory depression. So that is the reason we should not combine lorazepam with olanzapine or clozapine. And then coming to stable, so that is, so this is initial therapy. So first we have to reduce agitation. So for that, first we'll starting with one kind of antipsychotic, and the dose should be very much less, and slowly we have to titrate the dose. And if the patient is responding properly, we can increase the dose, and if he is not responding, we should stop that medication. We should go for another type of antipsychotic medication. Okay, and rapid titration should not be done. Slowly, gradually only we have to increase the dose. And while we are giving these drugs, like especially like clozapine or alloperidone, we should titrate very much slowly. Why? Because it may cause hypertension. And certain drugs like aripiprazole, olanzapine, haloperidol, they can be given IM route also when the patient is severely aggressive. And when we are giving this as IM injection, second dose also same should not be repeated. In that time, we have to add IM lorazepam as a maintenance therapy. Okay, and when we are giving lorazepam, we should not combine it with olanzapine or clozapine. Why? Because it further causes hypotension and circulatory depression or respiratory depression or CNS depression. So these two should not be combined. So this is all about initial therapy. And then now coming to stabilization therapy. Then now coming to stabilization. So stabilization therapy after the first week. So next 2 and 3 weeks, that goal is to improve socialization, self-care, and also we have to, and also self-care and mood. Improvement in formal thought disorder may require an additional 6 to 8 weeks. Like formal thinking requires again 6 to 8 weeks. Dose titration may continue every 1 to 2 weeks as long as the patient has no side effects. So dose titration can be done till 1 to 2 weeks until a maintenance dose is adequate dose has reached. And if symptom improvement is unsatisfactory even after 8 to 12 weeks at that given particular doses, then we have to change to another kind of antipsychotic or combination of drugs can be given. And then coming to maintenance therapy, so we have to continue the medication for at least 12 months, that is near about 1 year after remission of the first psychotic episode. And in most of the schizophrenia patients, lifetime medications is required. It's not like after the patient has become normal to stop the medication. It's like they has to continue the medication for their lifetime. And antipsychotics like first generation antipsychotics and clozapine, they should be tapered slowly. That like means after the patient is improving, we have to decrease the dose slowly, gradually before discontinuing. Why? Because if you suddenly discontinue the medication, it causes rebound cholinergic symptoms. So in order to prevent that rebound cholinergic symptoms, we should taper the dose slowly. And in general, when we are changing or switching from one antipsychotic to another, so first we have to decrease the dose of the first antipsychotic slowly for 1 to 2 weeks, and then we have to add second antipsychotic at a lower dose, and we have to titrate that second antipsychotic dose. So this is how we should go for maintenance therapy. And depot antipsychotic medications. What do you mean by depot? Depot is nothing but vial, like 10 ml. It comes in a 10 ml injectable thing. So that we call it as depot antipsychotic medications. So all the medications were not available as a depots. Only few drugs are available. It includes risperidone microspheres, paliperidone palmitate, extended release olanzapine, haloperidol decanate, and fluconazole decanate. So these are the drugs which are available as depot. That means as a vial, these were available. And when we are converting these drug oral antipsychotics to depot formulations, so first we have to stabilize on an oral dosage from the same agent, or that is from the same drug, or at least a short trial of 3 to 7 days should be given, and to ensure adequate tolerance. Okay, when we are going to give this depot antipsychotic medications directly, we should not start on depot medications. Initially, we have to give as an oral antipsychotic medications of the same drug, and after the patient is stabilized on the same with the same drug for 1 to 2 weeks, if the patient is stable with that medication, then we have to convert it into the same drug should be given as depot. And Risperidone is started at 25 mg. Usual dose range is like 25 to 50 mg. Deep IM every 2 weeks. Oral medication must be administered for at least 3 weeks after beginning injections. So even after starting these injections also, first we have to give these oral medications, and then we have to make the dose adjustments. Like the same for paliperidone, the dose is like 234 mg, and next 156 mg 1 week later, given in the gluteal or deltoid muscle. This is the deltoid muscle. Gluteal is at the back. No overlap of oral dosing is necessary. So when we are giving this depot, giving it as a depot, that is like an IM injection, it doesn't require any oral medication. When coming to risperidone, even we are giving IM injection, initially we have to keep them or give them oral medication also. Olanzapine, it can be administered for every 2 or 4 weeks by deep gluteal injection. The dose varies from 210 mg to 405 mg, and the patient may have post-injection sedation. That means after the injection, the patient may go into deep sleep or delirium syndrome. So that is the reason it has black label on its depot, or that is our vial. So when we are giving this olanzapine, it should not be given at home. Only it should be under healthcare surveillance only, healthcare facility only. We should give this olanzapine injection with patient observation by professional for at least 3 hours post dose. After giving the first dose, at least for 3 hours, he should be under the observation of a professional doctor or any nurse. And then for flufenazine decanate, the simplest conversion is the Stimmel method. So it follows a method called Stimmel method. So 1.2 times the oral daily dose for stabilized patients, rounding up to nearest 12.5 mg interval, administered IM in weekly doses for the 4 to 6 weeks. For every 1 week, I will be giving. This will be given for 4 to 6 weeks, and the dose could be like 12.5 mg. And subsequently, it can be administered once every 2 to 3 weeks. So first we have to give for every week for 4 to 6 weeks, followed by for every 2 to 3 weeks. So when we are giving this also can be overlapped. Means at the same time, they you can also give this oral flufenazine for the first week. And then coming to haloperidol. So when we are giving haloperidol, 10 to 15 times the oral dose is commonly recommended, and it targets around, like if you make a round figure, it calculates to be near about 50 mg interval. It has to be given IM once in a week with oral haloperidol overlap for 1 month. And administer haloperidol and flufenazine decanate by a deep Z tract, that is through IM method. And long-acting risperidone, deep IM in the gluteus maximus, Z-tracking is not necessary. So this is the algorithm. Stage 1A treatment. So individual with first break schizophrenia, Any antipsychotic monotherapy except clozapine can be given. Clozapine comes under second generation. So except clozapine, any antipsychotic for monotherapy can be given for stage 1B. So already if the patient is treated with an antipsychotic and if the treatment is being restarted, then we consider it as stage 1B. Stage 1A means first episode, then it is 1A. 1B is already the patient had taken this antipsychotic medication, stopped, and again we are going to restart. That comes under stage 1B. So in this condition, any antipsychotic except clozapine can be given, and an antipsychotic that previously produced poor efficacy should not be used as the patient has already taken the medication previously. Among that medications for which the patient has poor efficacy, the drug should not be given. Apart from that, any other antipsychotic can be given, and also clozapine should also not be given. And then coming to stage 2, so if the patients had inadequate clinical response with the first drug, either in stage 1A or 1B, if the patient is not responding properly to the first antipsychotic, then that condition comes under stage 2. So any antipsychotic monotherapy except clozapine not used in stage 1A or 1B can be given. So we have to change the drug. So which was used in the first step, except that and clozapine, any other new antipsychotic can be used. And if the patient has suicidal tendency, at that time we can consider clozapine also. And then stage 3, even after taking that single alternative antipsychotic monotherapy, if the patient is not responding properly, then we can give clozapine monotherapy. If the patient is not responding, then we can go for clozapine. And then coming to stage 4, minimal evidence exists for treatment options for patients who have not received an adequate treatment response with clozapine. So in that conditions, alternative antipsychotic monotherapy may be as good as augmentation or antipsychotic combinations. That means along with this antipsychotic, we can add one more antipsychotic that we call it as combination therapy. And what is augmentation? Augmentation means along with the antipsychotic drug, we'll be giving other drugs like mood stabilizers. Then we call it as augmentation. That means we are adding any other class of drug to maintain the patient stable, to keep the patient stable. So that is stage 4. So if the patient is not if he's not responding, we can change to injectable antipsychotic at either stage 2 or 4 if needed, if the patient is not responding properly also. So this is the treatment algorithm. And then coming to management of treatment resistant schizophrenia, that means if the patient is not responding to any medication, then that condition is called treatment resistant schizophrenia. So how can you manage this treatment resistant schizophrenia? So among all the drugs, clozapine was shown to be superior drug for the treatment of treatment resistant schizophrenia. So according to some studies, so it was found that, but it has a side effect called orthostatic hypotension. So that is the reason we cannot titrate the dose like any other drugs. Very slowly we have to titrate this drug, and first we have to give 12.5 mg test dose. If that does not produce hypotension, then we can go for 25 mg. And again, also we have to check for hypotension. If there is nothing like that, then we have to give the drug at bedtime, and later on we can increase the dose to 25 mg twice daily after 3 days. And then every 3 days we can increase the dose by monitoring regularly and closely his blood pressure levels until 200 mg per day is reached. So till then we can increase the dose slowly, first 12.5 mg, then 25, again we can add 25. In that way we have to add 25 till it reaches 300 mg. So more than that we should not give. So this is how clozapine should be given for treatment resistant schizophrenia. And then coming to augmentation therapy, along with antipsychotic drug, we'll be adding some other non-antipsychotic drug. So that we call it as augmentation therapy. Combination treatment means if we add two antipsychotics, that we call it as combination treatment. Augmentation means we'll be adding non-antipsychotic drug to antipsychotic drug. Combination means we'll be adding another antipsychotic to already existing antipsychotic drug. That is called combination treatment. Okay. So if the responder to augmentation therapy usually improve rapidly, then discontinue the augmenting agent if there is no improvement. So if the patient is improving, then okay, we can continue this augmentation drug. If the patient is not responding even after adding non-antipsychotic drug, then we can stop this non-antipsychotic drug immediately. So non-antipsychotic drugs which we use as augmentation drugs include mood stabilizers like lithium, valproic acid, carbamazepine. So these were used for mood stabilizing, and epilepsy trials were also can be used with along with olanzapine or risperidone. And SSRIs, that means selective serotonin reuptake inhibitors, they can be used if the patient has OCD like symptoms. So along with clozapine, we can go with this SSRIs. And when clozapine was given, the patient may show some kinds of symptoms of OCD, that is obsessive compulsive disorder. So in that conditions, we can add SSRIs. And combining one first FGA and SGA, first generation, second generation antipsychotic, or combining two different second generation antipsychotics can be suggested, and if a single dose is failed. And if there is no improvement within 6 to 12 weeks, we have to discontinue any one of the drug in combination therapy. So these were the different side effects. Aripiprazole, it causes sedation. EPS means extrapyramidal symptoms, anticholinergic symptoms, orthostasis, weight gain, prolactin. So these are the most common adverse effects of these drugs, antipsychotics. So this plus indicates one severity. Double plus means moderate, low. Triple plus means moderate. Four plus means three plus means moderate. Four plus means high. Plus or minus means negligible. So these were the drugs, these were the corresponding side effects, and how severe it was there, the risk of getting those side effects. This is a chart showing that. And then coming to anticholinergic effects. So among these, what comes under anticholinergic side effects? So anticholinergic side effects include impaired memory, dry mouth, constipation, tachycardia, inhibition of ejaculation, and urinary retention. So these were the anticholinergic side effects. Blurred vision. So these were the anticholinergic side effects. Elderly patients are especially sensitive to these side effects, okay, as they will be already having some anticholinergic effects. So elderly patients are more at risk of getting these anticholinergic side effects. It includes impaired memory, dry mouth, constipation, tachycardia, blurred vision, inhibition of ejaculation, and urinary retention. Dry mouth can be managed with increased intake of fluids. If the patient is having dry mouth, we have to improve the giving intake of fluids. If constipation, you should give some oral lubricants, ice chips, or the use of sugarless chewing gum or hard candy. No. So all these are used only for dry mouth only. Oral lubricants also for dry mouth. Ice chips can be given. Sugarless chewing gums or hard candies. So these can be given for dry mouth. For constipation, can be treated with increase in exercise, fluid, and dietary fiber intake. Coming to central nervous system, extrapyramidal symptoms. So what are the extrapyramidal symptoms? It includes dystonia, akathisia, tardive dyskinesia, sedation, cognition, seizures. So all this comes under central nervous system side effects. Okay. So extrapyramidal symptoms, dystonia. Dystonia means they will not be proper tonicity of the muscles will be lost. So prolonged dystonias may be life threatening, and so like trismus, glosspasm, tongue protrusion, oculogyric crisis, torticollis and retrocollis. So these were the torticollis and retrocollis. So these were the signs of this dystonia, and they occur primarily. This kind of dystonia can be seen in case of first generation antipsychotics. So the risk factors include younger patients, especially in male. This can be seen, and use of high potent agents at high doses. So when high potency drugs were taken higher doses, it causes dystonia. And treatment includes IM or IV anticholinergics or benzodiazepines. Benzotropine mesylate 2 mg or diphenhydramine 50 mg may be given as IM or IV, or diazepam 5 to 10 mg slow IV push or lorazepam 1 to 2 mg IM may be given for the treatment of this dystonia. And relief usually occurs within 15 to 20 minutes of IM injection or 5 minutes of IV administration. If the patient has come to hospital with the complaints of dystonia, so immediately the drugs that can be given as IM or IV were these drugs. If we have given IM injection, it takes near about 15 to 20 minutes to relieve from the symptom. Or if it is given as IV, it takes near about 5 minutes to recover. And prophylactic anticholinergic medications were also can be given in order to prevent this dystonia in young patients who are taking higher doses. So these were the drugs which were can be given for extrapyramidal side effects: benztropine, piperidine, trihexyphenidyl, equivalent dose. This was a daily dose range. Antihistaminics like diphenhydramine, dopamine agonists like amantadine, benzodiazepines like lorazepam, diazepam, or clonazepam, beta blockers like propranolol. So these are the drugs which can be given for treating extrapyramidal side effects. So, and also by reducing the dose also we can reduce or prevent these dystonias. And then coming to akathisia, so feeling of inner restlessness, pacing, shifting, shuffling or tapping feet. So these were the symptoms of akathisia. So treatment, if you are treating this with anticholinergics, there is no proper or response to that anticholinergics. So the only thing is we have to reduce the dose of the initial drug, and then we have to change to second generation antipsychotic. So benzodiazepines were also used to treat this, but there was no proper clearance that they responded to it properly. And certain beta blockers like propranolol, nadolol, metoprolol are reported to be effective, but there were no clear studies showing that these can be given. Pseudo-Parkinsonism means the patient will having symptoms of like Parkinsonism. Parkinson symptoms will be there. Akinesia, bradykinesia, tremors, rigidity, postural abnormalities. So these kind of symptoms can be seen. So the risk factors include taking high dose of first generation antipsychotics and elderly patients, mostly females. So they will be having these signs of pseudo-Parkinsonism. Accessory symptoms like seborrhea, siluria, hypererosis. Seborrhea means more excessive sweating, excessive salivation, fatigue, weakness, dysphagia, dysarthria. So these can be seen. This comes under accessory symptoms. So the onset of symptoms is 1 to 2 weeks after initiation of antipsychotic therapy or dose increase. So immediately after increasing the dose, if you are increasing the dose of antipsychotic drug, so after the increasing of dose, these kind of symptoms can be seen, or even after 1 to 2 weeks after initiation of therapy also, these kind of symptoms can be seen. So these symptoms are more with first generation antipsychotics compared to second generation antipsychotics, except for risperidone. And benztropine can be given. So diphenhydramine, amantadine. So these are also can be given to prevent like of whatever the drugs that will be giving for treating this Parkinson's disease. Same that kind of drug should be given. Tardive dyskinesia. So it's nothing but involuntary movements with chronic antipsychotic therapy. So if you're taking the antipsychotic medications for longer duration on chronic use, it causes tardive dyskinesia. That means involuntary movements occurring, and the symptoms like orofacial movements can be seen, like which will interfere with chewing, wearing dentures, respiration or swallowing, and facial movements like frequent blinking and frequent brow arcing, grimacing means that means continuously. This is grimacing, upward deviation of the eyes, and lip smacking. Lip smacking means continuously they'll be doing like this. So that is lip smacking. This can be seen in anxiety patient also, lip smacking. Continuously they'll biting their lips. That is lip smacking. So these were the facial movements which comes under tardive dyskinesia. And switching to clozapine is a first line strategy if the patient is having moderate to severe tardive dyskinesia. And prevention of that, for that, use second generation as first line agents. Use the discuss or other scales. So certain scales should be used to differentiate this tardive dyskinesia and to identify it in the initial stages. Sedation and cognition. So So these drugs should be given mostly at bedtime, and the dose should not be given in the daytime. Why? Because most of them has a side effects of sedation and cognition. So if you are giving these at bedtime, it will reduce this symptoms of hypnotics and sedation. And compared to first generation antipsychotics, second generations have shown cognitive benefits. Seizures. Higher risk of antipsychotic induced seizures is with the use of chlorpromazine or clozapine. So among all these antipsychotics, chlorpromazine and clozapine causes seizures, and this maybe can be seen in the initiation of treatment with higher doses or rapid titration of the doses. Seizures can be seen. So when an isolated seizure occurs, a dosage decrease is recommended, and anticonvulsive therapy is usually not recommended. So in that case, it's not required to keep the patient with anticonvulsants. Only if we decrease the dose or if we stop the initial dose, obviously seizures will not come back. So and no, there is no further any other anti convulsions are not required. And so this is all about different side effects, extrapyramidal side effects, anticholinergic side effects. So and also this also not only this, it also causes orthostasis, weight gain, prolactin, and it also causes hyperlipidemia. Few of these drugs cause metabolic disorders and also weight gain. So I can go through that topics also. You can refer them also. Then coming to evaluation of therapeutic outcomes. So regularly, what are the things that we have to monitor? Continuously, we have to monitor the body weight for 3 months. Why? Because olanzapine, clozapine, most of the second generation antipsychotics cause weight gain. And monitor BMI to check this BMI. We have to check waist circumference, blood pressure, as few of these drugs cause hypotension or orthostatic hypotension. Regularly, we have to monitor this blood pressure. Fasting plasma glucose. Why? Because they are at risk of getting diabetes mellitus. So we have to regularly monitor fasting plasma glucose. Fasting lipid profile. Why? Because they will be having hyperlipidemia after using these medications. At the end of 3 months, they should be checked regularly, and later on, for every 1 year, we have to check this. And these were the adverse effects, frequency, and comments. So if the patient is having akathisia, then we have to ask the patient about restlessness, or we have to check there is any anxiety, or every visit if the patient is coming, all these things we have to identify. And anticholinergic side effects, we should ask the patient if regarding dry mouth, constipation, unusual urinary retention. So regarding these symptoms, we should ask in every visit. We should ask glucose intolerance. So for that, fasting blood sugar or HbA1c that should be checked every 3 months. If it is normal, then we have to check for every 1 year. Hyperlipidemia. So for that, we have to check fasting lipid profile. It also should be at the baseline for 3 months. Regularly, we have to check for 3 months. If it is found to be normal, then every 1 year we have to check this. For orthostatic hypotension, we have to ask the patient if he is feeling any kind of dizziness when he is standing. And also, we have to check the blood pressure in the standing position also. And heart rate in the sitting and standing positions. So with that, we can identify or rule out this orthostatic hypotension, and this should be done on every visit. Hyperprolactinemia. So that means in women, if they are taking these antipsychotics, if they are having hyperprolactinemia, we have to ask about expression of milk from the breast and menstrual irregularities. And if it is in men, we should ask them about breast enlargement or expression of milk from their nipples. And also we have to check this serum prolactin levels on every visit. If the symptoms were absent, there is no need to monitor serum prolactin levels. Only if the symptoms are there, then we have to go for serum prolactin levels. Sedation, and every visit we should ask them about their sleepiness or sedation. That means even in the daily daytimes also if they are having sleep or not, that also we should ask them. Sexual dysfunction, as I said that some of them will have defects in ejaculation or difficult being aroused or problems with orgasm or decreased sexual desire. So these were the symptoms. So we have to ask the patient whether he is experiencing any of these symptoms. So most of the patients who are having schizophrenia, they will be having sexual dysfunction than the normal population. So compare the symptoms with medication-free state and tardive dyskinesia. So again, according to certain scale, we have to check whether the patient is having tardive dyskinesia. So for every 3 months, So we have to check these symptoms. Weight gain, we have to check their body weight, BMI, waist circumference for every 3 months, and then for every 4 months. So it also indicates cardiac morbidity. That means how far they are at risk of these cardiac disorders. And adverse effects monitoring parameters for specific antipsychotics. Granulocytosis, that means white blood cell and absolute neutrophil counts. So when you are giving clozapine, then only we should check this granulocytosis for every 6 months. And pylorrhea or excess drooling. So walking in the morning with a wet ring on his or her pillow, visual observation of the patient for drooling. This also should be done for every visit. Drooling means తూలినట్టు అవ్వడాన్ని drooling అంటారు. Bronchospasm or respiratory distress, respiratory depression, respiratory arrest. So when we are giving this inhalation of loxetine, so at that time we have to check for this. Every dose administration we have to check for this. Post injection sedation or delirium syndrome. So when we are giving IM injections or IV injections, so then we have to check this sedation or delirium. So every dose administration, at that time we have to check this consciousness, coma, delirium, confusion, disorientation, aggression, anxiety, cognitive impairment. So all these should be checked not only immediately after giving this injection, but continuously for 3 hours. The patient should be under monitoring after the drug has administered. So these were the different, so this is how we can evaluate the response of the patient. So with this, we have completed our treatment of schizophrenia. Thank you.